Good afternoon, everyone. We'll go ahead and get started. This is the VCU Department of Internal Medicine Grand Rounds. Today's session is sponsored by the Division of Cardiology. And before we turn it over to our chair to introduce Dr. Lemos, so just a couple of housekeeping items. For those online, we are still offering an option for in-person attendance here at the George Ben Johnston Auditorium every Thursday, 12 to 1 o'clock. Appreciate everyone attempting to come if you have the availability. Also will be recorded and made available online. The CE code is on the screen now. We will put that in the chat box once we get started, and also at the end of the lecture. If you have any technical questions, please use the chat to alert us. That's it for now. So let me start. I'll just introduce Dr. Gregory Hundley, who is the chair of cardiology and the director for the Pauli Heart Center here at VCU, to introduce Dr. James Lemos. Dr. Hundley?
Thank you so very much. I really appreciate the opportunity to introduce Dr. Lemos, and I've known James for quite some time. Just one of the most clear expert speakers in cardiovascular medicine today. He graduated from Harvard Medical School. He then accomplished his internal medicine residency, where we interacted at University of Texas Southwestern Medical Center. He was also the chief resident there, and so has a lot of experience in that regard. He then went to Brigham and Women's Hospital, where he did his cardiology fellowship, and he's returned now as a faculty member to UT Southwestern and holds the Sweetheart Ball Kern Wildenthal Distinguished Chair in Cardiology. James has been very interactive nationally with both the American College of Cardiology and the American Heart Association. He is part of the ST Elevation Myocardial Infarction Guideline Committee. He also has worked with the Food and Drug Administration and is a standing member of the Cardiorenal Advisory Panel, as well as the Endocrine and Metabolic Panel. Importantly, for many of us that work in the area of cardiovascular disease and practice cardiovascular medicine, he's the executive editor for Circulation, really almost the preeminent journal for cardiovascular diseases worldwide. He has really interesting primary research interests that involve early detection, risk assessment, and management. He has been an outstanding mentor to many. In 2015, he was awarded the Women in Cardiology Mentoring recognition by the American Heart Association. He, in 2020, had a Distinguished Mentor Award from the American College of Cardiology. And in 2021, the Meritorious Achievement Award by the American Heart Association. So, James, we want to thank you for visiting with us today here at VCU and presenting internal medicine grand rounds. And thanks also for all you've done really for us in the field of cardiovascular medicine.
Okay. Thank you, Greg, for that terrific introduction and for the hospitality that you and the entire division and department have shown me. It's been a great visit so far. So this morning I talked about work related to biomarkers and precision medicine to the cardiology division, but today at this noon lecture, I'd like to talk about some of the challenges that we and other institutions have faced implementing high sensitivity troponin assays into clinical practice in the emergency room in the hospital. I have disclosures related to grant support and consulting that I do for a number of the biomarker diagnostic companies that make troponin assays. And at the start, I'm going to be showing information from this 2022 consensus document that was led by Mike Contos here at BCU, and I had the opportunity to participate in, that really lays a pathway for introduction of high sensitivity troponin assays in the emergency department. And we'll show some of the consensus recommendations from this group over the course of the hour. The problem of chest pain is one of low value. So low risk chest pain, which is the vast majority of chest pain that we see in the emergency room, is low value care. It leads to extensive diagnostic testing, including obviously lots of troponin and other biomarker measurements, but also a lot of downstream testing that is largely not improving patient care. This is expensive and contributes directly to the problem of ED crowding, which was obviously accentuated during the pandemic. The situations around ED crowding are a public health issue and frankly, a public health emergency. Our hospital, our county hospital, Parkland, is on divert probably 2/3 of the days at this point. The US sees 7 million visits a year to the emergency departments for chest pain. At the same time, the testing in this space for emergency physicians is driven by the fact that missing a myocardial infarction is the greatest source of liability for ED providers. This leads to rampant testing, and I would argue over-testing of low-risk patients in the emergency department. When you consider that the assays that you're using at VCU already cause confusion with standard assays, and then layer on top of that, we're a few years into the introduction of high sensitivity assays, the current status is challenging at best. We're well aware at this point that even with standard troponin assays, there are many non-acute coronary syndrome causes of elevated troponins. Among the most common of these, pulmonary embolism, congestive heart failure, in emergency department settings. So patients that come in with chest symptoms, non-diagnostic EKG may well have a PE as the cause of an elevated troponin, not an ACS event. As many as half of decompensated heart failure admissions are associated with abnormal troponins, and about half of that group will have persistently elevated troponins. There are important prognostic associations of the elevated troponin in this context, but it makes it very challenging to use this biomarker to make definitive diagnoses. Other causes of elevated troponins in the hospital setting include sepsis, renal failure, and then what I talked about earlier this morning, chronic cardiovascular disease, particularly LVH and LV systolic dysfunction. This is a study that I think is still quite relevant, that a very nice analysis from a group in Israel that simply adjudicated all causes of elevated troponin in their hospital. This won't surprise any of us that do cardiology or internal medicine, but among their hospitalized patients, only half of the positive or elevated troponins were due to an acute coronary syndrome, and fewer than half of the low-level elevations. If you look at a more complex patient population that reflects the kind of people that are getting troponin measured in your healthcare system, older individuals with CKD, only 1/3 of the troponin elevations with a standard assay are from ACS, and only 1/4 of the low-level elevation. So the majority of troponin elevation you see in the hospital with a standard assay that you're using now are due to something other than acute coronary syndromes. So I showed earlier today data for high sensitivity troponins in the population. We actually started this exercise looking at standard troponin assays. This is the current or the previous generation Roche non-high sensitivity assay. We measured this assay in our Dallas Heart Study, which is a population-based cohort study that reflects the population of Dallas circa 2000. And with this assay, the upper reference limit, which is the 99th percentile, is 0.01 milligram per liter. And as should be expected, only about 1% of the population had a measurable troponin with this assay. What was interesting was that virtually everybody that had a detectable troponin in the general population had one of these 4 determinants of heart disease, either diabetes, LVH, evidence of heart failure, or evidence of chronic kidney disease. In the absence of one of these determinants, it was very unusual to have a measurable troponin in the population. Only 2 individuals in the population without one of these factors had a measurable troponin. But as you add up a greater number of these determinants, the risk or the probability of elevated troponin was substantial, about 30% in individuals that had 3 or more of these determinants. This was actually the work that led us to anticipate high sensitivity troponins as potential useful markers for population screening, given that we saw a clear adverse phenotype even with the standard assay. But the challenge for our emergency department colleagues is this scenario, diabetes, LVH, CKD, incredibly common, using troponins to diagnose acute MI when the population prevalence of abnormal troponin is 35% or so, makes it challenging and makes it difficult in the emergency department, not just to sort out acute heart failure from acute MI, but even acute from chronic myocardial injury. So this is an algorithm that I like to show our house staff, just because I expect them to determine the etiology of an abnormal troponin in cardiac injury, because it's important. If the troponin is above the 99th percentile or detectable with the standard assay, cardiac injury is present. It's never normal to have cardiac injury, but it's our obligation to really take the next steps and try to identify the mechanism of injury. If the pattern over serial measurements, or when compared to a previous measurement, is flat, meaning that there's minimal change over serial measurements, we call these chronic elevations. This is what I talked about this morning. This is a marker of structural heart disease, renal disease, but not of acute myocardial infarction. When the temporal pattern of the troponin over serial measurements suggests a rise and fall, and the larger the rise or the larger the fall, the more confident we are that there's acute injury, then this is indicative of acute myocardial injury, but it's just the first step really to diagnosing acute MI. We need to identify an ischemic mechanism along with acute injury to diagnose MI. And that ischemic mechanism can come from dynamic EKG changes, ST elevation, depression, clear T-wave abnormalities, echo findings that suggest a new wall motion abnormality, a smoking gun in the cath lab, or with CTA that suggests anatomic obstruction, or if all these are absent, if the ischemic history is convincing, then that may be enough to make the diagnosis. Even when it all falls together, we've got acute injury, we have an ischemic mechanism, we're not done. I should say that in the absence of these, we now use the term non-ischemic acute injury. So the categories include chronic injury, non-ischemic acute injury, that is most commonly caused by heart failure, pulmonary embolism, myocarditis are the most common causes of non-ischemic acute injury. And even when we have the clear evidence of ischemia, we have to take the next step, and this is really important on the internal medicine wards and in the cardiology services, is to try to make the designation as to whether the picture is consistent with a spontaneous plaque rupture event. These are the type 1 MIs that we actually know how to treat, versus acute MIs that are caused by acute supply-demand mismatch without plaque rupture and thrombosis that we call type 2 MIs. I want to emphasize, I find when I round that there are cognitive, as I get older, I'm much more interested in cognitive biases. And for some reason, when we're young, we have a cognitive bias that tries to adjudicate all acute injury to something other than MI. We use terms like troponinemia and troponinosis. And we also are more likely to classify MI as type 2. I will suggest that to diagnose a type 2 myocardial infarction, unless the patient has known severe disease, you need to show me a smoking gun. You need to show me a market imbalance in supply and demand sufficient to cause myocardial necrosis. And that could be on the supply side, profound anemia, profound hypoxemia. On the demand side, it's going to need to be things like hypertensive emergency, marked tachyarrhythmias and such. So in the document that Mike led, a talented junior investigator at MGH named Kian McCarthy put together this algorithm to suggest possible management strategies for type 2 MI. These are not evidence-based because there's absolutely no evidence to guide us in terms of this common condition. But the focus is really on treating the precipitant of the supply-demand mismatch and delaying basically initiation, if possible, of some of the acute antithrombotic agents and immediate catheterization. Some of these individuals will have known coronary disease and have a supply-demand mismatch on top of that, and generally they should be managed generally similar to type 1 MI, except since many of these are medically complex patients at high bleeding risk, a more cautious approach to antiplatelets and antithrombotics. If they don't have known coronary disease, it's probably worth first performing an evaluation with the transthoracic echo to look at the degree of LV dysfunction and wall motion abnormalities, and on a case-by-case basis, considering anatomical evaluation or functional evaluation for coronary disease. And in some patients, this may be a CTA or a cath or a nuclear stress test when the dust settles. But in general, focusing on treating the underlying comorbidities, addressing supply-demand mismatch, and reevaluating the patient once the acute issue has stabilized. Now, when we have acute myocardial injury without evidence of ischemia, in general, an echo is recommended because, as I mentioned earlier, structural abnormalities, LVH, unrecognized LV dysfunction or valve disease are common. Again, we want to try to identify and treat precipitating factors. In this context, CMR, magnetic resonance imaging, and you all have a phenomenal program here, has a higher priority, looking for things like myocarditis, which is a frequent, when the dust settles after evaluation of ACS, and anatomic coronary disease is excluded. Myocarditis, as I'll talk about in a minute, is not uncommon at all. When the myocardial injury is chronic, then echo is indicated, and then focusing on secondary prevention strategies when indicated, blood pressure control, lipid lowering, if they meet current indications. There is very little known and much to learn about how to evaluate and manage type 2 MI, and even more in the areas of acute and chronic myocardial injury. So even when patients look for all the world like they're having a classic spontaneous type 1 myocardial infarction, and we take them to the cath lab, it's not at all uncommon to find that the patient does not have a smoking gun. They don't have an obstructive lesion or evidence of atherothrombosis. And we now use a term called Monoca, which is an umbrella term to reflect the various pathophysiologies that may contribute to myocardial infarction with no obstructive coronary disease. The most common etiology is probably a missed plaque rupture erosion that reflects the limitations of coronary angiography. And with advanced imaging tools like optical coherence tomography, for example, you may see a plaque rupture or erosion. And so the first step is to take a second and third look at the coronary angiogram and make sure that the obstructive lesion hasn't been missed. In some places, in some circumstances, more advanced imaging may be needed. Microvascular or epicardial coronary vasospasm in our population, often in the setting of cocaine use, may be an explanation for Monoca. Spontaneous coronary dissection, an increasingly important etiology for myocardial infarction, can present with the spectrum from unstable angina to non-STEMI to STEMI to sudden death, may represent as much as a quarter of MIs in young women, may be very difficult to diagnose with the standard angiogram because without classic findings. And OCT, again here, showing a clear dissection flap can help to identify this. Coronary embolism is another mechanism. This can happen, of course, in atrial fibrillation, but also in endocarditis, LV thrombus in the setting of non-ischemic cardiomyopathy. Takotsubo cardiomyopathy is a neuroendocrine stunning of the ventricle that mimics acute MI, really recognized after anatomic imaging when the coronaries are normal and you see a characteristic anterior apical wall motion abnormality. And then, as I mentioned, CMR has a powerful role at the end of the initial evaluation to identify myocarditis. It turns out that for those of us with a lot of gray hair like me, we learned that myocarditis was a heart failure mimic diagnosis. But in point of fact, the vast majority of myocarditis presents as acute MI mimics with chest pain, troponin elevation, EKG changes, and MRI has emerged as the diagnostic modality of choice. So with that introduction, which unfortunately just highlights the tremendous confusion of interpreting troponins and diagnosing myocardial infarction, we asked the question, can high sensitivity assays help with this diagnostic mess? And the answer is, well, yes and no. And we're going to talk about sort of the pluses and minuses. I know you all are considering implementation and have implemented at the VA. But there are a number of potential advantages of high sensitivity troponin assays in this confusing space. The first is improved MI diagnosis. The improved sensitivity may lead to fewer missed myocardial infarctions. And as we'll talk about at length, this allows us to shorten the period needed to rule out MI. It may lead to improved risk assessment that may allow us in the appropriate patients to move towards definitive anatomic treatment with invasive therapy sooner. And identify patients who don't have an MI but have mildly elevated troponin levels who are at risk for long-term complications along the lines of what I talked about this morning. And then really the focus of a good part of what we talked about this morning is these high sensitivity assays have applications well beyond the emergency department. We talked about applications for population screening. They have potential applications for disease monitoring and in all kinds of non-cardiac disease states, pulmonary hypertension, endocarditis diagnosis, diagnosing transplant rejection, et cetera. But there are a lot of disadvantages. Virtually all cardiologists and hospital medicine physicians are already frustrated with troponin elevations that they use pejorative terms like troponinemia, troponinosis, using contemporary assays. And there is, we know that, as I've mentioned, only a minority of troponin elevations are from MI. And they have, we have, unfortunately, when we identify these, they're frustrating because we don't have the evidence-based solutions for either evaluation or management when we identify cardiac injury. We know the patient's at risk, but we don't know what to do. And there is zero question that with the implementation of more sensitive assays, the number of individuals you'll identify with chronic injury and with non-ischemic acute injury will be increased. And I'll show you the data to support that. So really, you know, the diagnosis of non-STEMI just becomes more confusing. And as somebody that believes strongly in high sensitivity troponin, I don't believe that it makes the diagnosis of non-STEMI any simpler. I think it makes it even more complicated. But these assays have actually been around for a while. We've just been slow to adopt in the US. They were launched with a back-to-back papers in New England Journal in 2009. This is data from a study that I'll show other findings from over the course of the hour called Apace. It's a Swiss study led by Christian Mueller. And in this study, what they're showing is the area under the diagnostic ROC curve comparing the standard Roche troponin T assay and several high sensitivity assays, and demonstrating that the area under the diagnostic ROC curve for the sensitive assays is substantially better than the standard troponin T assay, but that difference is magnified in the early hours after symptom onset and is lesser the longer you wait. What's not often talked about is that this improvement in diagnostic performance is a trade-off. Sensitivity increased, if this is looking at the 99th percentile for both the standard and the high sensitivity assay, sensitivity increases from 83 to 95%, which leads to an improvement, but a small improvement in the negative predictive value from 97 to 99%. But the trade-off is that specificity is lower. So in this loss in specificity correlates with a reduction in the positive predictive value from 72 to 50%. So the negative predictive value, to remind you, is how likely the patient is not to have an MI if the test is normal. The positive predictive value is how likely the diagnosis is to be MI if the test is abnormal. What they don't talk about in these European studies is that the population in which these studies are done is dramatically different than who we measure troponin in the United States, where in our hospital, 40% of ED visits get a troponin at Parkland Hospital, which is remarkable, and it's no lower at our university hospital. And so what does this mean? So that there is an established role of high sensitivity troponin outside the US, but there are important differences in the US. We dramatically, arguably overutilize troponin testing in the US among individuals with a much lower probability of MI and a lower risk. And a point that is controversial, but Mike and I agreed with in that consensus document, is the ambiguousness of the 99th percentile value. It's highly dependent on the population studied. There are important sex-related differences that if you don't use sex-related cut points, you probably underdiagnose myocardial infarction in women. And applying this in the US is challenging. We did a little exercise. So the study I just showed you that launched the high sensitivity troponin assay had an MI probability of 17% in the cohort. And if you apply the operating characteristics from that study with the sensitivity and specificity, the number of individuals in their study that per 1,000 that were abnormal with the old assay was about 200. An additional 130 or so individuals were identified as abnormal with the more sensitive assay. And in their study, only 21 of these 130 that were newly abnormal and caught with the high sensitivity assay had MI, and the other 108 had something else, acute injury or chronic injury. In my hospital, the probability of MI is under 3% if you have a troponin measurement. If you look at that 130 individuals in that circumstance, only 3 out of 130 of the newly detected individuals with these low-level elevations will be diagnosed with MI. The vast majority will be diagnosed with something else. So there's real risk of taking out of the box, if you will, the European recommendations or using troponins in the same way we always have if we use these high sensitivity assays. So, it's sort of I was very worried, initially, because there wasn't a lot of talk about how to best use these initially. We already massively overtest troponins among individuals with a low pretest probability, and that, has the potential of leading to a tsunami of abnormal troponins with that would challenge the cardiology consultants in the healthcare system in terms of what to do with it. And so, I think it's important to note that the ex-US data really can't be applied out of the box in the US, and simply replacing your old assay with a new assay without thinking about the best way to use the new assay could lead to downstream struggles in terms of resource utilization and characterization of risk. And so there is a solution, though, and the solution is to, and I think Mike really laid this out very nicely in this document, but the solution is to implement the high sensitivity assay together with the structured clinical decision pathway that maximizes the intrinsic values of the high sensitivity assay. And I'll sort of highlight the rationale for that and then show you some of the data to support that. But these assays are better. They are technologic advances that are more sensitive, but that's not the only advance. The other major analytical advance is that they're more precise, but this greater sensitivity allows us to exclude very small elevations that would be well below the typical MI threshold. And by excluding minor elevations, that allows us to exclude or rule out myocardial infarction with a single blood draw in the emergency room, also in your outpatient practice, even someday maybe at home with a single blood test if the troponin's low enough. The other big advantage is that these assays are more precise, so they're less noisy, and they're precise enough that we can use them over very short periods of time. We can perform 2 measurements an hour apart and use those to exclude very small changes. And remember that the diagnosis of acute MI requires acute injury, which requires troponin change. So if we exclude change in troponin, the patient doesn't have an MI. And so we can use the exclusion of change, capitalizing on the precision of the assay, to rule out MI in a couple of hours among individuals. And I'll show you some of the algorithms that have been developed. So how well does this sort of single draw rule out work? And this is across, the first data came from a German group by Bodie, looking at a high sensitivity troponin below 3 nanogram per liter. About a quarter of their ED population had a troponin less than this, and that none of those individuals were eventually adjudicated to have MI. Now, one of the issues in the US is that the US FDA has not allowed the troponin T assay to report down to such a low level. So the lowest level that the Roche 5th generation or high sensitivity troponin T can report to is 6 nanogram per liter. But even at this threshold, if somebody has 3 or more hours of chest pain and an undetectable troponin, that represents about 1/3 to half of the individuals, the negative predictive value is between 99.5% and 100%. So you pick up the probability of MI if the troponin is undetectable at presentation is extremely low, and that allows a single measurement rule out in a substantial number of individuals. Now, in one of the earliest applications of machine learning that I'm aware of in cardiovascular medicine, the Apace group, led by Reichland, used a machine learning algorithm to use the baseline measurements and change values to categorize patients using a data-derived approach into 3 groups: a group with low initial levels and very small changes or no change into a group that they assigned rule out, a group with higher levels, and let me point out, this is considerably higher than the 99th percentile value. This is about 3-fold above that, or larger changes into a rule-in group, and then left everybody else in an observation group. But in this algorithm, the 60% of individuals were assigned to rule out, and the sensitivity and negative predictive value were 100%. 17% of individuals were assigned to rule in with a positive predictive value of 84%. Recall that in this same study, when you just use the 99th percentile value, the positive predictive value is 50%. So by moving beyond the simple threshold approach and incorporating both high levels and change, your positive predictive value goes up. But the elephant in the room is that quarter of the patients get assigned to this observation zone in sort of no person's land where and no guidance is provided. This was replicated in a study that included North American individuals where the Ruleout group had a high negative predictive value, but not 100%. I think it's unrealistic to expect that kind of replication performance, and the positive predictive value was about 70%. What is recommended in the document that Mike led is for this group in the intermediate risk zone, that's a group that is intrinsically at higher risk because these algorithms, these are people that have more comorbidities and more risk factors. So they need to stay around in an observation unit, an ED, or in the hospital for at least 3 to 6 hours with repeat troponin testing. It's also recommended that they undergo risk stratification with an established ED-based risk stratification algorithm. And then they get reclassified at 3 to 6 hours. And I won't go through all the details, but if their information, their EKG remains unchanged and their troponins don't increase further, many of these individuals can be discharged without being formally admitted to the hospital. But if they demonstrate higher risk features, then they should undergo further evaluation, either with imaging or admission to the hospital. So there is now a wealth of evidence, largely from outside the U.S., that that you're able to. Sorry, this. Is there a way to hide this?
So click more and just hide the floating window. Down. Right.
Yeah. So if you look across multiple studies, about 60% or so of individuals using these complicated algorithms can be assigned to a rule-out zone and discharged within an hour of presentation. Unfortunately, about a quarter to a third get stuck in this observational zone where there's not a lot of evidence and guidance. So how might this work in the US? Because the probability and risk are both lower in the US than they are in ex-US, we expect that the safety is likely to match or exceed what's seen outside the US. The caveats for this include that this type of algorithm is not suitable for early presenters because troponin may take up to 3 hours to rise. So this can only be applied to people that have had chest pain for 2 to 3 hours. Another thing, if you don't read the fine print, is that most of these studies from Europe didn't actually discharge the patients at 0 or 1 hour. So they show you these great data about low risk, but the patients weren't actually actioned at 0 and 1 hour. And there's very little data on what the most appropriate strategy is for testing individuals after they have MI excluded. I'll come back to that. We recommend in the document, we're taking an approach that these individuals are at such low risk that the large majority of them require no testing at all and just outpatient follow-up. So in this 60% of individuals, their troponins with very low troponins, the vast majority of them can be dispositioned without any testing. The problems with these algorithms include this large intermediate or observation zone and the fact that they don't consider additional information that you and I would always consider from the EKG and other presenting features. So as you think about implementation strategies, and as I understand it, you all are thinking about this here, there are a number of different approaches that can be taken. There are many places that use troponin-only strategies, don't incorporate information from the EKG or clinical information. There are some simple algorithms that incorporate troponin with the EKG. And then there's algorithms like ours that use a troponin-based strategy, but incorporate information from risk assessment to decide which individuals can be dispositioned to which locations, home, observation, hospital, and what testing to do. And among the tools that are best used are probably the modified heart score. This is the most evidence-based risk assessment tool for emergency chest pain. It's a simple tool, and your emergency room is likely already using this. And then I'll say that this area, there's much interest in this space in machine learning algorithms that are agnostic to time, and the big advantage of machine learning is that it handles missing data very well. So for messy ED type databases, it works well. And there's a lot of academic and commercial interest in machine learning algorithms to tackle the problem of chest pain with high sensitivity troponins, as well as all the other clinical information we have. So we were, I believe, the first large US medical center to implement high sensitivity troponin in 2017. And what we did is we took the protocols that that had been developed and validated in Europe and put together a multidisciplinary team to develop one that might work in our hospital with an assay that didn't report to as low a level, which is the high sensitivity troponin T. Now, from the back of the room or on Zoom, the overwhelming message from this is how complex it is. This is one of the clinical decision pathways. It is complicated. There's no simple algorithm that allows optimization of these. And what they typically do, all of these algorithms, is they take a low or undetectable initial troponin, and if the symptom onset is 3 or more hours, they're ruled out, and rule out is in green. If the troponin is greater than 52 at any time point, we call this abnormal. I want to emphasize, and I'm guessing VCU has a fairly similar population to Parkland. We never use the word rule in our algorithm, and I'll show you why, but because the vast majority of these are not MIs, they're just abnormal. If they don't meet rule in or rule out or abnormal, then they are considered indeterminate. They undergo another measurement at 1 hour. If the change is small, they rule out. If the change is large, they're abnormal. And if they don't rule out or considered abnormal, they go to 3 hours. And one difference in our protocol is that we force a decision at 3 hours so that there's not an observation zone. And so if the troponin change remains low, we disposition those patients. Our data look okay for this, but I will point out that this needs to be replicated because some of the European studies that have looked at our algorithm suggest that this may be too aggressive in places where the MI probability is high. I think importantly, for the group that rules out, we use a risk assessment scheme to decide what to do next. So we use the modified heart score. And if they rule out at 0 or 1 hour, by definition, they have low troponins and minimal change, and their modified heart score is less than 3. We don't do any testing at all. We just disposition that patient home. If they either are at higher risk or rule out later, meaning they have higher troponin values, then we consider either outpatient stress testing or CTA, or a pre-discharge CTA for those that are at the higher risk level. So we are a low testing institution in general, and we try to reserve testing for those that are intermediate or higher risk. The other thing that's important as you think about what to do is how to handle the abnormal values. So we explicitly, and we have turns out that our ED department chair is good friends with Mike Contos and an expert in the biomarker space as well. So she's been a great partner for us. And so we've eliminated hair trigger admissions for abnormal troponin values. And so we require the patients to have clinical evidence of ischemia or another indication for admission to cardiology to come to cardiology. And if they don't have another indication for admission, we try to get the ED to handle this. Now, of course, they're independent providers. They admit anybody that they want to admit, but we spent a lot of time on education to try to remind people that an abnormal troponin, while it may identify long-term risk, doesn't always need to come to the hospital, and certainly doesn't always need to come to cardiology. So we ran before we actually implemented live. We ran our algorithm behind the scenes and compared it to our standard rule out, which was high sensitivity, a standard troponin at 3 hours. And with our standard algorithm, we ruled out about 79% of individuals, and 21% had abnormal values. With this new accelerated clinical decision pathway, we ruled out 84% overall, an increase in 5%. And you might look at that and say, that doesn't seem that impressive. But when you're measuring at Parkland almost 3,000 troponins a month, and if you can disposition 5% more of those to home or to observation, that may make a meaningful difference in terms of ED crowding. But I think equally important, 30% of those ruled out at time 0 and 54% at 1 hour. So we ruled out more people and we ruled them out faster. And in the context of this small pilot, sensitivity and negative predictive value were 100%. I want to emphasize, though, that the positive predictive value, remember in the European studies, it was 77% or so, or 80%, but those are places with an MI probability of 17%, 20%. Our MI prevalence is 3%, and thus our positive predictive value is only 20%. So even with these complicated algorithms, the huge majority of abnormal values are from something other than MI, and that's why we don't ever use the word rule in with the algorithm. So what about our decision to force this issue at 3 hours? So what this of these individuals at 3 hours, the vast majority of them ruled out. Only 2 that we tested at 3 hours were moved to abnormal, and the other 152 were moved to rule out. And again, none of these individuals ended up adjudicating to MI. Now, Rebecca Vegan, who's an outcomes researcher at our institution, did a nice study in which she looked at the year period prior to implementation and then the year after implementation to look at what this did with regard to emergency department flow. And what she observed was that the proportion of individuals discharged directly from the emergency department increased from 48 to 54%. Fewer patients went to observation and fewer patients went to admission. I will emphasize that this does have a major impact on ED flow because patients get discharged directly from the ED a lot more instead of having to go to observation for longer periods of observation. So things like blood pressure, lipid management, and other disease management have to happen in the emergency department. And then when she looked at ED dwell times and disposition times, the time from the troponin first measurement to when the patient leaves, they appeared to be modified by the intervention. If you look at ED dwell times, they were dropping slowly, and this is the minutes that were falling per month pre-intervention, and this trend was accelerated after the intervention. That difference was significant. And if you look at troponin time to disposition, this was actually increasing prior to the intervention, and then this was flattened after the intervention. This is the best you can do with time data. This is observational data, and we don't know for sure that it was the implementation of this CDP that did this and not other ecological trends in the emergency department, but this was favorable. But then the most important piece is we have to make sure that our implementation was safe. And we have the advantage in Dallas of being able to track people after they leave our hospitals. 70 out of 72 hospitals contribute ED and admission data. And we looked at the rate of MI or death among people ruled out pre and post intervention, and the rate remained very low. So there is no spike in adverse events post implementation. So we then implemented at our university hospital, and then we actually converted from high sensitivity T to high sensitivity I. And I'm happy to share this algorithm. We ended up simplifying the algorithm. We looked at our data, and we could sort of eliminate one step. So this still looks really complicated, but it's actually much simpler. And all of this is embedded, the orders, everything's embedded in the electronic medical record. And it happens, even though these look complicated, this happens sort of below the level of individual clinical decision-making, and all happens, frankly, before the internist or cardiologist sees the patient. There have now been some other observational studies that support these CDPs working well in the US, which I think is important. This is data for a new troponin I high sensitivity assay showing, again, about 50 to 60% rule out with these assays and with these algorithms, and the negative predictive value of close to 100%. So the ACC consensus pathway recommends these high sensitivity troponin clinical decision pathways, but I wanted to emphasize the upstream piece of it is that people should have symptoms that are concerning for ACS. It should not be applied, in our view, to people who have ischemic EKG findings. So the first step in the ED or on the floor, if you're going to use these to disposition patients, is exclude major ischemic EKG changes. And Mike is an expert in this area. And then they need to have chest pain onset of 3 or more hours before you start. And if they meet these criteria, then they're good candidates for these CDPs. If they are abnormal with these, we need to think about using the diagnostic criteria that I started with. If they're low risk, then we recommend, as I mentioned, discharge with outpatient follow-up and no testing for the vast majority of these individuals. So that is likely to be cost savings, and we think likely to be safe. This is just for reference purposes. We summarize the data. These sorts of algorithms can be done with all of the available high sensitivity assays on the market. So what can we learn from other countries about what we're likely to see in the US? So this is an interesting study that looked at implementation of high sensitivity troponin assays in Sweden. They're able to track all of their MIs and abnormal troponins in the Sweetheart registry. And when they implemented high sensitivity troponin, they had a modest relative 13% increase in the diagnosis of MI, but a 230% increase in the troponins from unspecified disease and a doubling in troponin elevations from other diseases. So you're going to see small increases in the rate of MI when you implement, but large increases in acute and chronic myocardial injury from things other than MI. There have been a number of innovative studies. This is what's an in-practice RCT. What they did here, this is Derek Chu, is they used high sensitivity assay and they randomized the patients to either get all the information or to blank the levels that would be detected, blank the high sensitivity assay to levels that would only be detected with the standard assay. So they could compare an algorithm like I've been talking about, these 0-1 hour clinical decision pathways with a standard protocol. And what they observed in a randomized fashion is that the proportion discharged from the ED increases from 32 to 45%, and the median length of stay in the ED drops. But there seemed to be a slight reduction in testing, but there is zero improvement in outcomes. And this is a recurring theme, that the implementation of these approaches does not improve patient outcomes. It improves patient flow. It gets patients out of the ED faster, and it's a process improvement, but it's not, it doesn't improve outcomes. And frankly, that's, if you think about it, the idea that a test result is going to improve outcomes is probably unrealistic. Another algorithm, this is from a group at University of Edinburgh that one of the real leaders in this space, Nick Mills, who has done a series of powerful studies in this space. He has a clinical decision pathway called high stakes that is somewhat different from what I showed you. I won't go through the details, but this is definitely a viable option for implementation. And in a series of studies, what Nick and his colleagues did was first roll out a high sensitivity assay across Scotland in an organized fashion. When they rolled out the high sensitivity assay, they reclassified 17% of individuals to abnormal versus what they were doing with the standard assay. And unfortunately, there was no difference in clinical outcome for these people reclassified. So by identifying, again, proof that this is about patient flow, that by identifying additional individuals at risk, at least at this point, that didn't lead to improved outcomes. They did see very important differences in risk in their study. So this is all individuals that are below the MI threshold, below the 99th percentile. If you're completely undetectable, your risk is low. If you're between the 5th percentile and the 99th percentile, your cumulative incidence of MI or cardiac death is notably higher. In the group below 5 nanogram per liter is just mildly above baseline. The importance here is that while we don't in 2022 know how to handle these patients, these individuals we're identifying with the high sensitivity assays that fall below the threshold we would have detected are at increased risk. And I think you'll see increasing research designed to identify what to do with these individuals. This will be information that in the long run is going to be important. Another really useful study that Mills and his colleagues at Edinburgh did was called Historic. This was a very elegant study design called Stepped Wedge, which is a great way to test the rollout of new technologies. And so they rolled out in a stepped wedge clinical trial their high stakes algorithm across Scotland. And they saw that, that this early rule out pathway reduced the length of stay in the emergency room by about 3.5 hours and increased discharge from the ED by 57%. But again, it did not improve clinical outcomes. So improved process, you might infer that in an era of ED crowding where patients can't get to the ED, that there may be indirect benefits, but the clinical trials haven't supported that. So I'll conclude here. A novel clinical decision pathways incorporating high sensitivity troponin testing shorten the time to rule out MI. They may reduce excess resource utilization, particularly if you leverage that low risk group to limit secondary testing. They're safe, but they don't improve clinical outcomes. They identify more patients with type 2 MI and cardiac injury than standard pathways. And when you implement, you really have to consider that up front. There is not a simple algorithm that will allow safe and effective implementation. These algorithms are complex and require a lot of process engineering to put these in the EMR. And I'm not going to talk about this in detail, but they require new metrics for quality improvement because the timing of the measurements ends up being very important. And it didn't used to be when you just measured troponin at baseline in 3 or 6 hours. But if you're looking at a temporal change over 1 hour, you have to make sure that your ED staff and nursing and lab are getting the measurements when you think you're getting them. If these algorithms are implemented carefully and deliberately, we can see faster and more accurate disposition of chest pain and clearer evidence, I think, of improved ED efficiency and hopefully reduction in crowding. Of course, these changes are happening during other ecological trends like COVID and things that drive ED crowding, shutting down of inner city ERs and such. I'm going to stop there and leave the rest of the time for questions.
We'll start with any questions here in the audience. We have a portable mic that we can pass around if people have questions. Thomas, I can do it. Ladies first. There's comments. Works.
Lighter boards might be better.
Thank you. And a quick first question to the lobby first. So please help me enjoy this one. Question for you. So I think one of the things is, maybe we can see the issues in the EU and important. And for everybody that lies here, other patients with PhD colleagues, and the question is, how do you then take care of these patients who have risk factors? We've got some enrichment that are incorporated in our healthcare system. You get the whole idea of rapid access to cardiology or other
Yeah, it's a great point. I think that the key is that to do this well, everybody has to be aligned, from hospital administration to lab medicine to radiology to cardiology, hospital medicine. There's even impact on surgical services where you find that troponins have been measured in strange places in your hospital. And we had to, one of the things we had to get buy-in for in a county hospital was that regardless of insurance status, or even if they qualified for the county-based healthcare plan, that we would provide a follow-up visit, period, because otherwise you can't ask the emergency department to discharge these patients without follow-up, or and so that's part of the package, for what is presumed to be cost savings and efficiency in the ED, is that there has to be a place to see these patients, and so we, now, the honest truth is that in our system, that doesn't mean the patients are actually going to come back for that follow-up visit, but we have a mid-level based post-ED chest pain follow-up clinic that we stood up to handle the greater number of these people that would be going home. The other piece of it is the risk factor control. Which was always present, but would arguably have been dealt with in the observation unit by the mid-level practitioners that were taking care of these patients, and that has frankly been an ongoing education with the emergency department. And I know I've known Mike forever, so I know that you all already have a pathway here with a lot of cardiology involvement in the ED, so you have a presence in the emergency department. That sort of is half of the problem. We do a lot of cardiology consultation in the emergency department as well, so we still see a lot of patients who rule out and provide input. But we ask the ED to address, to address. That doesn't mean they always have to treat blood pressure, lipids in this population. And in the document that Mike led, there's actually specific recommendations for how to handle things like blood pressure, lipids based on patient risk and whom to treat. And then the last point is that coronary CT angiography is increasingly becoming the test of choice when testing is done, and dealing with incidental findings as well as non-obstructive coronary disease is sort of another layered piece to your question, and encouraging the ED to start statin therapy, for example, in patients with non-obstructive disease identified, and not automatically admit them to the hospital.
Thanks for your talk. So, in the front hospital, program director and doctor, hospital based coaches. Curious about your thoughts about the overnight inpatient treatment, chest pain, insurance call. They're like, oh, the center for calling, they're coming in the morning, they say, well, it's probably going up with their baseline dying with that. Do you see use of this potentially for that kind of patient down the road, or would that be studied or evaluated?
Great question. Yeah, so we use the same algorithm for inpatient rule out. It works. We initially we debated whether to have the one-off troponin, but we allow so when we have an order set that initiates the troponin protocol, which is basically up to 3 measurements, but it cancels the measurement if the first troponins if they meet the different steps. But then but yeah, it works just fine in the hospital. A lot of times in the hospital, doctors will order a single one-off high sensitivity troponin, and we allow that. But yeah, it is effective in that context. Obviously, many of them will have abnormal values, and it will have to be, interpreted in the context of the abnormal values. And again, I don't think these assays provide any help on the rule in. It's equally, if not more messy than it ever was. So all those messy patients that are hard to figure out what the troponin is elevated from, it will not get any better.
Quick question in the chat online. Dr. Mayer says, perhaps the folks with intermediate range high sensitivity need a multi-pronged approach aiming for weight loss, tighter control of blood sugars, lipids, so forth. Is there any role for diabetic educators in the emergency room to help triage those initial high-risk diabetic patients?
Well, that's a great suggestion. I think this area is ripe for innovation like that. I think that would be a very innovative approach. I think along the lines of what we talked about this morning, but capitalizing, these non-MI troponin elevations are important information that we're capturing now that we didn't capture before. And I think innovative programs that are designed to address this risk are needed. Now, they all have to be studied, because I don't know at this point what actually of these approaches is going to work to lower that risk. And that risk is only based on what we talked about this morning. That risk is only minimally atherosclerotic events. A lot of these people are at risk for heart failure and AFib, and even troponin actually predicts all-cause mortality. So it's likely to be multimodality. These people need, the people who have minor elevations do need closer follow-up than the people that are completely undetectable. But beyond observation and risk factor management, we don't really have a lot of evidence.
We have time for maybe one more here in person.
What would you interpret when the sensitivity troponin is after the 3-hour mark from the initial onset of symptoms? For example, I had a patient once who made like a change in his chest and thought I had sensitivity troponin, and he was normal. He was admitted to something else, and then the past 3 hours we got like a recent sensitivity troponin and it increased. But that's something that you would consider, like, even though there's an indication needed, he's not having those symptoms anymore, continuing to follow even after 3 hours.
Well, in general, that would be a miss of the assay, because if in general the evidence, and none of these are perfect, but in general, if the chest pain onset is 3 hours or more, and the troponin after the 3-hour period is negative, these algorithms don't typically recommend a second measurement. Now you may decide clinically, like you did here, because you're worried about the patient, and none of these, I do want to emphasize, none of these these are decision aids. They don't trump clinical judgment. And if you're concerned about the patient, you should continue to observe them. And but in general, most patients who have 3 or more hours since the onset of chest pain and a troponin less than that rule out threshold, that would be undetectable, don't need a second measurement. This patient's an exception, and that happens about 0.5% of the time.
Other questions? Thank you, Dr. Lemos.